we would moderate this meeting, and then I guess we will have the presentations, and then we can speak about discuss it at the end. So, Risto, would you?
Thank you very much, Gilo, for the introduction. Welcome to everyone in this net meeting. It goes very smooth. I'm very exaggerated about the results we will accomplish. So maybe we shall go on to the presentations. I wonder who will be the first presenter.
I guess it's Genevieve Malfilater.
Maybe Genevieve,
yes, I say it well, from Belgium. So would you please start your lecture? Then I'm ready to use parenteral nutrition. Please turn on the microphone because you are off at the moment.
Okay, sorry.
Thank you.
And I don't know how it will work. Because do you see my presentation? So, good afternoon. Thank you very much to invite me to share my experience with our way of prescribing PN solution. I was not aware I had to present something. I was aware that we will share our experience, but I have quickly made something just to explain you how we are working in the Tivoli Hospital in Belgium. I'm one of the 19 intensive care unit of my country. I'm a neonatologist. Oh, sorry. Okay. So I'm a neonatologist for 30 years. I'm working with 6 colleagues in a level 3 unit with 20 intensive beds. We have a year around 400 admission, mainly preemies baby. And we have around 80 small one a year, very low birth weight a year. And we use, for all of our patients, we use the Numeta 3-chamber bags solution. We have the 3 different Numeta solution, the G13 and the G16. We use it with a dilution in the bag for most of our children. And I would say the easiest patient who don't need special need. For the smallest one who do need really special need, we have another way of using the 3-chamber bag. We apply a Y dilution. And also for the biggest baby who are experiencing some really intensive care we are really for the biggest who are in a very difficult condition. For example, the perioperative babies or the asphyxiate baby, we also use a Y dilution on the side. And we use it not with a computer prescription, but we just use a chart. And this is our chart, which can look a bit complicated, but it's just an easy board that we use it every day. We use both solutions, so the G13 and the G16. You know the composition of these two solutions, and we have chosen color for different components of the solution, and we put these numbers in a box. And this is the box we are working with every day. This box for the G13 and the G16 is the composition of the PN for 100 milliliters. And so it means also 100 milliliters per kilo. So it means that you have here in blue the amino acid, the lipid in orange, the sodium and potassium intakes in purple, glucose in green, calorie intake and calcium in gray. And so this is the amount for 100 milliliters. So it's also 100 milliliters per kilo. This is the composition of the solution every day from 50 milliliters per kilo to 150 milliliters per kilo. And this is the composition of the PN we give to our baby if we apply a dilution in the bag. 50 milliliters, 100 milliliters, 150, and 200 milliliters for the G13 and the G16 solution. And the same if we use it without the lipids. This is the chart with the lipids, and this is the chart without the lipids. So how do we proceed every day? According to the weight of the baby, we choose one solution. This is the in the bag dilution, and this is more à la carte or tailor-made solution for the smallest one. Sorry, my text is sometimes in French, but I quickly prepared this presentation. Sorry again. So this is our board to help, and this is where we prescribe the solution. It's still on a paper, but we don't have so many choice. We have many choice, but we send this paper to the pharmacy and we can't write on the prescription. We just can tick the boxes, which is a security. So this is which Numeta solution this is the Numeta on the left-hand side, upper part, the solution we use. On the right-hand side, this is what we add in the bag. And in the last square under the sheet, this is what we use on a Y line if you choose to do so. And so the dilution are done in the pharmacy under a laminar flux. Vitamins are prescribed apart in a syringe. Ionic addition are also apart in a syringe. Prescription and biology check are done around 8:30. And we receive the answer at 10, and the new perfusion are applied at noon. So this is quite a narrow period of time to decide what we will prescribe to the child according to the biology check. So the dilution in the bag will suit almost 80% of our patients. This is what we call our volume guide way of working. So we prescribe a volume, and everything the baby we think he need, is inside the bag according to the proportion chosen by Baxter, and check, of course, with clinical trials, and we participated to 2 clinical trials for that. So we are really aware of how to manage with that solution in an easy way of everyday working. And so we just add water in the bag, and if we need some ions, we put it on the side. If we have more difficult patients, like the very tiny one or peri-operative term babies, very unstable, we choose the wide addition, the wide way of working. And so we can add the water and the nutrient, the complement of the nutrient on the side. And this is what we call the nutrient guide prescription. So it means that we will choose one Neonatal bag with or without lipid, G13 or G16, and we will choose some addings, water. So water is now on the side, and ions are also, addition of ions are on the side, and in the 24 hours following, we can change that proportion. It means that we don't have a tailor-made really prescription, but we will change it hours per hours according to updates of biology or blood gaze sampling. That's all. It's just to make it short. I didn't know what you expect, but it was just to show you our practical way of working. If you have any question or later question.
Thank you, Geneviève. Thank you very much. May I have some words? We in Bulgaria, we are not working with these standard solutions, but yes, it seems wise to use them. Having this information for 5 to 10 minutes, it seems quite complicated, but I feel that when you're working on a daily basis with these calculations, it's easier not only for you, but for the nurses also, and the pharmacy. And of course, this way of using standard solution carries all the advantages of the standard solutions.
In fact,
it seems for me, who are not working with them, that we'll have just to start with something. What would you advise us how to start?
In fact, what I haven't told you is that I start with that board, and I was on call yesterday and I had a very bad night. That's why it seems a bit not in order. But in fact, I haven't explained properly the board. You've seen colors in the board and different intensity of colors. And the point is to prescribe inside the colors. It means that it's safe if in my board, the prescription is done in between the colors. It means that it's safe. And that's what young doctors, nurses, pharmacists, and colleagues have to know. It means that you can't go outside the color prescription, either because it's too loud, too much amino acid or too much lipids, or it's too light, not enough. So if you have to start with that solution, I would advise to do it easily with the 22, 24 weekers, for instance, who are quite easy to manage and who are not so unstable for the water and the salt, and get step by step to more difficult patient. For instance, the perioperative patient or the very small one who lose a lot of water. And for the very small one, we choose to use the Baxter Nueta all-in-one solution as a basis. And we prescribe the water on the side just to be able to adapt on the 24-hour basis and not to have a fixed solution for the next hours, as we know that those small babies can be very unstable with the water load inside.
As I understand, this standard solution is not a fixed one. It is prone to changes.
Yes.
According to the condition of the babies.
Yes.
Which this impresses me because we know that babies are quite different and their condition also.
For stable baby, the dilution is done in the bag. So I mean the baby who receive a mix of enteral nutrition and PN solution, and day by day we apply a dilution in the bag or not at the end. When the quantity of the PN are small, we do not more put water inside, as we use it on a central line always. In very few cases, we use it on the peripheral line, and in that case, we always make a dilution in the bag to meet the osmolarity, the safe osmolarity.
Thanks, If you used the central line, do you include umbilical venous catheter in this term central line?
Yes.
And how long are you going to keep umbilical venous catheter on site?
In our unit, we keep it quite long according to the other center, and I have to say that we really don't have problem with that. We keep it till the 4 or the 7 days we keep it till the 7 days if we see that we can reach the total enteral nutrition without placing another central line. If we understand that this baby is too ill, we will need anyway 10 or 15 days of PN. We will change it quite quickly after birth. So
and do you put this umbilical catheter immediately after birth, or you wait for 6 or 24 hours?
Immediately.
Immediately.
We are almost we are maybe only seniors in our unit. We have trainee, but they are never alone. So we are always able to put any catheter.
I'm not afraid about the technical side, but we were taught in the years, of course, 15 to 20 before, that keeping umbilical venous catheters for more than 2 or 3 days isn't very wise. But for my own opinion, we are keeping them longer, and I see that sometimes this is the only way to be able to treat very premature infants and to keep the IV lines on site for a long time. And we have to learn also to put vena cava catheters, not peripheral vena cava catheters more frequently, which is the other way of having central venous lines.
Absolutely, we do it also, but I would say for a baby of 1.8 kilo, we will try to feed him totally in 1 week. And as we have a NICU philosophy, we try to arm them the less as possible. And this is why, but I fully understand and I agree absolutely. But this is what we try day by day.
Thanks very much, Genevieve.
Thank you.
Gila?
Just one question. I have one question that if you have a hyperglycemia, you just go after it with insulin infusion, or how can you change? Because it would be difficult to change this solution.
Because it's impossible to change the solution, we choose in that patient usually the unstable one. It's mainly the smallest one who are unstable for the glycemia, we use some water on the side. And first, if we have an hyperglycemia, we try to add more water. For instance, 24 milliliter per day, for instance, first to start. It depends on the size of the baby. And if it's not enough, we put insulin. And if it's not enough, we bring down a bit for a few hours the amount of the PN. But our solution is mainly adding water.
And is it not a problem? I mean, the osmolarity can widely change with adding water. So, I mean, you showed on the table that you can even give thrice so much water.
It's inside, always inside the central line. So it never becomes hypoosmolar. The water is mixed with everything. It's in a single lumen or double lumen catheter, but the water is also always mixed with the PN. So it means that in the PN, it would be as it had been in the bag. So it's never hyperosmotic. It's always mixed with the PN. So it can't be hyperosmotic. It's never on the peripheral line that we use that way of working.
I see. Okay, thank you very much. I think we could switch to the second
Speaker.
Sure.
Yeah.
The second speaker, and that would be, I guess, Elena Maggiora from Italy.
Hi, nice to meet you.
Hello.
I'm very happy to be here, and thank you for the invitation to be here. I try to share my screen. Okay, hope it is working. Good afternoon, everybody. I'm happy to be here and to share the experience of Dr. Crazy and mine in using ready-to-use parental nutritional bags. I'm going to show you our experience. I work in a neonatal intensive care in Turin, which is in the north of Italy. In our center, we have 2.5 to 3,000 births per year. And I work in a NICU with 17 neonatal intensive care beds. Our patients are mainly preterms, but we are also a regional referral center for neonatal surgery and a hub for neonatal transport. So our patients are lots of premature babies and sick babies. And this is the reason why we use a lot of PN bags. We generally use parental nutrition in all babies born with a gestational age below 32 weeks, who can't be obviously full-fed enterally, and in all the babies born with a gestational age between 32 and 34 weeks, requiring an intravenous support and expected to require more than 2 days to reach full enteral feeding. We administer parenteral nutrition both through central and peripheral lines, and we use it until an enteral feeding volume of 115 ml per kilo per day is reached. Until 3 years ago, our hospital pharmacy provided customized parenteral bags every day, except during public holidays and during the night. In such cases, when a parenteral bag was needed, it was prepared by our nurse in the NICU. And then at some point, we had a staff shortage that forced us to reduce the demand for customized bags requested from the pharmacy. And so we realized that the standard bags available in the market were not adequate to meet our needs. And that preparing all the parenteral bags in the world placed too much burden on the nursing staff and could lead to preparation errors. So we have to face the problem, and we start from what the expert stated. And so that the standard PN solution should be used also in the newborn patient and also in the very small premature infants. That individually tailored PN solution should be used in the very sick baby and unstable babies, and that it's better to use a computerized prescription both for the standardized and individualized PN bags. So we aimed at reducing the prescription of the customized parenteral bags to the pharmacy, widening the availability of the standard parenteral bags, and developing a computerized system to prescribe parenteral nutrition recipes and select the best match among the available standard bags. To do this, we create the RIBES concept, so the ready-to-use and individualized bags embedding system. We then widen the options of the parenteral bags, and we create 10 recipes, and we so obtain 10 standard parenteral bags produced by an external provider. We developed a software that put together ESPGHAN recommendations, the enteral nutrition intakes the baby is receiving, and its clinical characteristics, and which is able to select the best bag among the 10 standard bags we created, or rather to address the prescription to a customized parenteral nutritional bag, with the choice was not possible among the 10 standard bags. How does it work? So you put in the system the recommended nutritional intakes, enteral nutrition the baby is receiving, some of its clinical characteristics, and the software automatically generated a prescription. This is what we see on our software. These are the desired nutritional intakes, all nutrients per kilo per day. And this is the enteral intakes, and this is the amount of fluids from drugs. When you prescribe the PN, you can check if your prescription, if your intakes are in line with the ranges of standards proposed by the ESPGHAN, and then you can see automatically the prescription of the PN made by the software. Now we have to see if there's any standard bags that fits the prescription. If we have one, the software automatically selects the parenteral nutrition bag which best fits the prescription. This is an example. In this case, the bag number 9 was the best one, and the one the software selects. You can again check if your prescription is in line with the standards of the ESPGHAN Society. And here you can see the out of range between your prescription and the actual composition of the bag. We decided to tolerate a 10% difference between the prescription and the composition of the standard bag. If there's no bag available which match your prescription, we then face with the pharmacy. If the pharmacy is available, the software produces a customized parenteral nutrition prescription, which is this one. So the prescription for the hospital pharmacy. And if the pharmacy is not available, we decided to adapt the standard parenteral nutrition bag. So the software again select the best bag, and then we can add each nutrient to the bag, just pressing that buttons, and the software make the changes to the bag to obtain the best match. Or maybe if we need to dilute it, the software add water to the bag. This is so the prescription that comes to the nurses. They say they can see, which bags they have to prepare, and they have the precise volume of each nutrient that they need to add to the bag. We asked if it was working, so we did an observational study. We selected the most fragile and unstable babies, the one born below 28 weeks of age. We selected a case cohort with the babies born between 2021 and 2024, when we start using standard PN, and compare it with an historical cohort of babies born between 2019 and 2021, when we used only customized PN. The first thing to see is that there were no differences in growth, and this is important for us. And instead, we saw a difference in the time to reach full enteral feeding, which was reached earlier in the case cohort, so using standard PN. I don't think it's only due to the use of standard PN, because in these years we also changed our enteral nutrition protocol, but it's important to say that using standard PN is not inferior to use customized PN. The same things we can say about PN complications. For example, you can see that hyperglycemia and insulin use and severe hypernatremia were higher in historical cohort. But again, I think that the important thing is that case cohort, so the one in which the standard PN bags were used, is not inferior to the historical cohort. And I think that these differences are mainly due to the fact that using this software, you can calculate precisely the amount of fluids and electrolytes which comes from the drugs. We also did a cost analysis. This is the cost of a customized PN bag, and this is the one of a standard bag. Applying this software and this way of work allowed us to save about 300,000 euros in these 3 years. So to conclude, I can say that the integration of customized PN and standard PN in neonates is possible, effective, and cost-effective. And by using integration protocols that focuses on the actual nutritional needs of the patient, the system can also be applied in high-risk neonates. And thank you for your attention.
Thank you, Elena. Does anyone has any questions?
Sorry, I have a technical question because it was not clear for me. So you mentioned that you add the nutrients to the bag. Is it do you have to open the system for it? So I mean, or you mentioned some buttons. I did not really understand. So I mean,
yeah. So in the case the bag does not match completely the nutritional intake you want to give to the patient, you may add some elements, or in an epsilon way, or inside the bag. The nurses have a place to do that, which is safe. We use it just only when the bag is not perfectly matching our needs and when the pharmacy is not available, so it's a limited condition.
Is it not elevating the risk for infections? I mean,
it's not changed during the years we observed before and after the introduction of the system.
Mm-hmm. So there was no change any, I mean, late onset sepsis or line infections before. Did you make a a match between the historical and the new groups, cohorts, if there is a difference in infections, line infections?
We did not observe any differences in the onset of infection before and after use of this protocol.
Elena, I want to ask, maybe you use the bag and change the bags each day. Is it possible to leave this bag for another day, having in mind that usually, especially the very low birth weights and extremely, they have quite a small amount of fluids per day?
But we change the central line every 24 hours. So anyway, we change the bag. Even if it's the same bag, we change the bag.
Yeah, thanks. So, Gila, maybe we shall go to the other speaker because time is going on in order to have time for questions at the end.
I don't know if there is any question from the public, because
I also don't see any questions from the public.
Okay, thank you. Then we would ask Barbara Krolak-Olejnik for the lecture from Poland. Thank you.
Sorry, now everything must be okay. Sorry.
Yeah.
But I can't change my presentation. Yes. Okay. Sorry. Thank you very much for invitation for this very, very interesting conference. I am from Poland. I am from the University Hospital in Wrocław. It's one of the biggest hospital in the Lower Silesia and one of the biggest in the Poland. We have a neonatal ward, not only NICU, but also we are close to the delivery room. And during 1 year, we have about 2,000 newborns, and I have 16 NICU beds. During 1 year, I have about 400 babies in this NICU, not only very small birth weight, but also a lot of babies with congenital malformations, because we cooperate with the surgery units in the one of the biggest in the Poland. I have the presentation about not only my work, but also about the experience of neonatologists in Poland. Because in Poland we have standards of nutritional management, which was written by Polish Neonatal Society, and we have complied this recommendation with SPGN and also European and world recommendation, and 2 chapters deal with nutritional therapy. But standard is in force, but we don't know in what way working our neonatal words. It means we have recommendation about components, but we haven't recommendation about kind of bags. Then we prepared a short survey on nutrition of newborns in the Polish NICU. Newborns born before 32 gestational week. We invited to participate in the survey all neonatology wards in Poland. We have 56 hospitals where we have NICU, but we sent only to the NICU which cooperate with delivery departments. It means only to the NICU which are near to the obstetrician and don't hospitalize people from another hospitals. And look, we received feedback from 42 hospitals. It means 75 of all links sent to the hospitals. Then first questions were about the kind of hospital where the NICU is, and about 45 NICUs are in Poland in the university hospitals. But the second question was about how many babies under 32 weeks of gestation are hospitalized in the NICU. And look, we have a lot of NICUs which we have very small, very low gestational age babies. It means that about half of them have only 50 or less babies during 1 year. Babies very small of gestational age and born under the 32 weeks of gestational age. Only 16 of these hospitals have more than 100 babies under 32 weeks of gestation. Then one of the questions was when parenteral nutrition is implemented, and almost each of hospitals implemented the parenteral nutrition during the first day of life. But what kind of parenteral nutrition is used? And look that 85 of these hospitals said that it's individual bag of parenteral nutrition prepared by pharmacy according to the doctor's prescription. And 35 of them said that they use ready-to-use bags, but these hospitals could answer for this first and the second questions. It means, I think, that some of them use ready-to-use bags and also individual bag of parenteral nutrition. But look that only 13 of these hospitals, it means only 30% of hospitals in Poland use ready-to-use bags of parenteral nutrition. But the next question was, does the hospital have a parenteral nutrition laboratory? Because it's necessary and follows from the Polish law and recommendation of Ministry of Health. And only 57% of these hospitals said yes. That means that they haven't parenteral nutrition laboratory, but use bags prepared by pharmacy. Probably a lot of hospitals in Poland buy this prepared by pharmacy bags of parenteral nutrition from another hospitals, not only from the pharmacy in their hospitals, but they don't use ready-to-use nutrition bags. What about my hospital? We have this department in very big hospital, and we have pharmacy which prepared us parenteral nutrition according the doctor's prescription. But we don't have pharmacists on duty during whole day and whole weekends. It means that when we have babies at night or at the weekend or day which is free, we use ready-to-use bags. It means during the first days of life, sometimes we use these ready-to-use bags. We know that according to the recommendation, this parenteral nutrition isn't comfort for the babies, but we check that in these bags, sodium intakes of 2 millimole per kilogram per day during these first 2 postnatal days didn't result in increased incidence of hypernatremia, and also the potassium intake from these ready-to-use bags during these first 2 days was found to prevent early hypokalemia. And our observations are consistent with the data from the publication from the 2 years from the Journal of Pediatric Gastroenterology and Nutrition. This publication is from Scandinavia, and they also talk us that it's possible to use these ready-to-use bags during first days of the babies. In Poland also the payer, but we have only the one payer in Poland, it's National Health Fund, covers the nutrition treatment, and for total parenteral nutrition, each hospital, each NICU could receive 300 points for each person day. It means it's about 100 euros. So we can safely use ready-to-use bags in any hospital, especially in this one, which have no a parenteral nutrition lab. I think that in Poland we can educate medical personnel about parenteral nutrition. We have this written recommendation, but as you know, we have it's in the book, but not each person could prepare the parenteral nutrition according to this recommendation. And what about we a lot of afraid, it's this parenteral nutrition prepared by the pharmacy in the other hospitals and transported this parenteral nutrition to the NICU, where in the hospital they didn't have this own lab. That it will be better to use, especially for these babies, and especially for these units which hospitalized not so many patients, because as you see, as you saw, we have a NICU which hospitalized only, for example, 20 preterm babies with the birth weight below 1.5 kilogram and born under the 32 gestational age. Then maybe in these hospitals it would be better to use ready-to-use bags. It's one of our room in the NICU when we have free bags for the babies. Each of these babies here have individual bag of parenteral nutrition. Each of them is intensive treated. Thank you for attention, and we haven't so many experience with ready-to-use bags, but we use them during the first 2 days after the birth. Thank you for my time. Thank you.
Thank you, Barbara. Your experience fits my feelings about the ongoing development of parenteral nutrition. Yes, in Bulgaria we also have quite a lot of units which don't have much very premature babies, and surely they have problems with parenteral nutrition, which may be lessened by using standard bags. I'm not sure whether in Bulgaria it will be cost effective, but even not very cost effective, we will have to start somehow, because it seems that it will make the life easier for the doctors in these smaller units and also in the bigger ones. Any questions?
I have a question. Yes. So, as I understood, your bags are prepared by the pharmacists. So that means that under laminar floors, also, I mean that for sterilely, but so it's prepared locally, and it's not an industrial parenteral nutrition, as far as I understood.
Yes. Yes, but in my hospital, we prepared parenteral nutrition in our hospital pharmacy. But as I know, in some hospitals, they couldn't do it. Then they prescribed this reception and sent to the small factory which prepared parenteral nutrition and sent it to the hospitals, especially for the small units for the babies.
So after all, you have standardized bags, and if you have a baby during not during the weekend, then the neonatologist will prescribe an individual solution, and that is also prepared by the pharmacists.
Yes, it's individual bags, but as you can imagine, it's not possible to send this bag during some hours. Sometimes it's prescription during the morning, and the bag is sent during the evening or during the night, or sometimes on the second day. That it's individualized for the babies, but not in this time when the baby needs this parenteral nutrition.
See. Okay. So after all, as we saw, we have different solutions for the same problem, because as you said, you prescribe it and ask the pharmacist to prepare. Then in Belgium, it is so water is added as it needed, and in Italy, I mean in Turin, it is you have different bags, and then you choose the best one which fits the best for the patient. So it's interesting to see the answers for the same question in different places.
Yes, you're right.
It would be very interesting what they're doing in Turkey. Maybe some of the hosts is following the session, because really there are quite great differences between the implementation of the same guidelines.
I don't know. I think Coach can be here, but I don't see. She reacts.
Yeah. She's online.
Hello, can you hear me and see me?
Yeah.
Yes.
Hello to everyone. Yeah, actually, in Turkey, some of the units use these ready-to-use bags, and some of them still use compounders, and or locally they prepare their TPN in their units, because as all the speakers have told about, sometimes our colleagues say that they can see hyperglycemia, and sometimes it's not so easy to control these TPN bags, especially in extremely low birth weight or high risk infants. But we have some long holidays, and during these times or at the weekends, or at nights. Now we started to use and prefer these ready-to-use TPN more and more. But still we have some problems and we have some discussions on this issue.
So do you think it's better to use the standard bags and make modifications to them, or just to do it individualized if possible? What would you prefer?
To modify them has some risk for infection. Actually, we have to use them without doing any modification, I guess. But we have a lot of level 3 NICUs in Turkey, more than 450, I can say, in all the country. So some of them, especially the units with bigger babies, can use it effectively because we don't have all the compounder units in all the level 3 NICUs, I mean. So preparing it in local units, I think it's not very, how can I say, not we cannot do it because of the infection risk, because we have high infection risk in some units. So because of that, I think we will use it more these ready-to-use TPN bags. But I don't think that modification of these TPNs can help us, especially for the risk of infection.
Thanks.
After umbilical vein, do you use Premicat or some
yes, we
peripheral
use.
inserted central lines?
Yes, central lines, we use it, all of them, because we have, especially in some units, we have babies under 600 or even 500, and some of them are surviving. And because of that, especially in these units, there are more problems, of course, and we use catheters, central catheters also.
Well, thank you. It's 5 minutes past 6. I don't know if it is not time to end the session.
Yes,
Any
I think we
questions?
can. Yes, end the session, especially if there's no question or anything. I'd like to thank you all. And as we come to the end of this Nutri Update meeting, on behalf of Turkish Neonatal Society and UNPS, I would like to extend my gratitude to each of you for your valuable contributions and participation. A special thank to the speakers, chairs, organizers, and Baxter Company, whose efforts made this meeting a success. Let us continue to collaborate and share our knowledge and experience to improve our outcomes for our babies. So looking forward to seeing you all at the next events, and I wish you a nice, happy week, and thank you again, and I would like to say goodbye.
Thank you very much.
Good.